At, at the end of this lecture, you should be able to describe the pathophysiological processes causing acute renal failure and some corresponding clinical causes, explain the management of patients with early kidney injury, recognize the features of a patient with established acute renal failure, and describe the management of established acute renal failure, including when to start dialysis. Renal failure is failure of solute and usually water clearance. It is common in ICU and is associated with increased mortality. Oliguria is defined as urine output less than 0.5 mL per kilo per hour. It is often a warning sign of impaired tissue perfusion and may progress to acute renal failure if not corrected. As a result, 2 hours of oliguria must be treated urgently. Before we go on, spend a minute thinking about the question on the slide. Although the kidney has an extremely good blood supply and receives a high proportion of cardiac output, it is very susceptible to ischemia. This is due to heterogeneity in the balance between oxygen delivery and oxygen demand in the kidney, with the juxtamedullary area being very prone to ischemia. This area contains the distal part of the proximal tubule and the ascending limb of the loop of Henle, one of the metabolically most active parts of the kidney, and therefore has a high oxygen demand. Unfortunately, the arrangement of arterioles and venules in this region is such that the arterioles are descending towards the medulla and the venules are ascending into the cortex. This results in a countercurrent exchange for oxygen, with the result that the oxygen delivery to cells in this area is marginal under normal circumstances. This area is, therefore, very susceptible to any reduction in oxygen delivery. Reduced renal blood flow worsens medullary ischemia, causing structural changes and ultimately acute tubular necrosis. There are multiple causes of kidney injury in critically ill patients. Some are unavoidable, but many are avoidable, in particular hypovolemia, shock, and nephrotoxic drugs. It is important to identify those patients who have unavoidable risk factors and pay particular attention to avoid exposing them to avoidable risks. In the critically ill, the most common cause of acute renal failure is renal hypoperfusion, leading on to acute tubular necrosis. The key to management of acute kidney injury is early treatment, with the aim of preventing progression from mild kidney injury to acute renal failure by treating treatable factors and by restoring renal perfusion. The earlier the treatment, the higher the chance of restoring renal function. This chance goes down the greater the delay, and severely delayed treatment will result in acute tubular necrosis. At this stage, the deterioration is irreversible in the short term, and treatment is aimed at the complications of acute renal failure. We're going to pause here for a minute, think about 2 important learning points so far and why they are important. Investigations are aimed at assessing severity, determining cause, and detecting complications. If the urine dipstick is positive for blood or white cells, urine should be sent for urgent microscopy for casts as well as for culture. Renal biopsy should be reserved for patients with suspected vasculitis or glomerulonephritis, especially if a trial of steroids are considered. Renal ultrasound should be performed in all patients with unexplained acute renal failure to exclude obstruction. As we discussed, it is important to identify and treat the treatable factors. This involves resuscitation, relief of obstruction, including urinary retention, resuscitation, antibiotics and aggressive source control for sepsis, stopping nephrotoxic drugs where possible, decompression of abdominal compartment syndrome, and treatment of rhabdomyolysis. Resuscitation involves correcting any hypovolemia, restoring cardiac output, and restoring perfusion pressure. Furosemide should be avoided at this stage, although it may have a role after adequate resuscitation. There are currently no specific treatments that improve creatinine clearance or speed renal recovery. Dopamine may increase urine output by an inconsistent diuretic effect, but it does not increase creatinine clearance or prevent progression to acute renal failure. It does cause serious adverse effects and is fundamentally not useful. Furosemide similarly does not improve creatinine clearance. It does have a role in the management of fluid status, but only after adequate resuscitation. Established renal failure is indicated by the features shown here. Once the patient has established acute renal failure, management should focus on avoidance of volume overload, treatment of complications, adjustment of drug doses, and renal replacement therapy. Restrict fluids to the previous hour's urine output plus insensible loss, but do not withhold nutrition if it is indicated. Indications for urgent renal replacement therapy are metabolic acidosis, hyperkalemia, and severe fluid overload unresponsive to diuretics. In order to buy time while setting up renal replacement therapy, treat hyperkalemia with insulin and dextrose, bicarbonate and beta agonists, severe acidosis with bicarbonate, and volume overload with nitrate infusion and/or furosemide. Write down 3 key learning points on the lecture, 3 things you think would be important to tell a colleague who did not hear the lecture. I'll give you a minute to do this. In summary, oliguria is a warning sign of shock and acute renal failure. The earlier the treatment, the better the renal outcome. Volume repletion and restoration of normal cardiac output and blood pressure are crucial. And the goal is to avoid established acute renal failure and to avoid the need for dialysis.